اه واضحه يا دكتور محمد.
Okay. Okay. Naratinib, as we mentioned, is another tyrosine kinase inhibitor. That's the tyrosine kinase intracellular pocket here of the receptor. Lapatinib will block HER1 and HER2. Naratinib will block HER1, HER2, and HER4. That's why we call pan-HER inhibitor. HER3, it does not have a tyrosine kinase domain, tyrosine kinase pocket, so it cannot be blocked. HER3 is not, it doesn't have a tyrosine kinase domain here. In the early studies, it has a very promising activity as a single agent, but it was pretty toxic when it comes to diarrhea. Molecular weight is much smaller than lapatinib. It is almost half of that of lapatinib, so it has a potential for CNS penetration more than lapatinib. In a small phase 2 trial of patients with brain metastases who did not receive lapatinib before, the overall response rate with naratinib and capecitabine was around 50%. So it's not bad. Progression-free survival is 5.5 months. But in prior, as expected, prior lapatinib in the same study, the performance of naratinib is much less. We had high hope of naratinib in the metastatic phase, that is naratinib capecitabine versus lapatinib capecitabine in patients as third line and beyond treatment. It was more than 600 patients. It's not really impressive. Progression-free survival is somewhat longer, significantly when in terms of statistics, but it is 6.6 versus 8.8 months. There was no improvement in overall survival. The response rate was a little bit higher, not significantly higher, 33 versus 27. But what was really better is the duration of response. So naratinib, it induces more prolonged responses compared to lapatinib. For the CNS patients with CNS metastases, the time for CNS progression was prolonged with naratinib compared to lapatinib. The difference was not significant, but the trend over the Kaplan-Meier curves is very clear. If anything, it's a little bit better than lapatinib capecitabine. But tucatinib is something else, actually. Tucatinib is a still smaller molecule, but it is very selective inhibitor for HER2. Remember, lapatinib and naratinib, they block as well HER1. But for tucatinib, you need a very large dose of tucatinib to block HER1. While naratinib blocks HER1 and lapatinib blocks HER1 at a small dose, very equivalent to HER2 blocking. Tucatinib is a selective HER2 blocker for that reason, and it has a small molecular weight, less than 500. In preclinical models, actually, of brain metastases, it was suggested from this that the survival of animals treated by tucatinib, that's the green, was better than naratinib and lapatinib. Of course, you need to prove this in the clinic. In the phase 1 study, tucatinib plus trastuzumab and capecitabine were quite safe, and they were having promising activity. So it was designed to give take care of the patients included in this study, the HER2 CLIMB study. Everybody should fail trastuzumab, pertuzumab, and TD1. So very heavily pretreated patients. The comparator was trastuzumab and capecitabine, and the tucatinib arm was added adding tucatinib to trastuzumab and capecitabine. So it's a triplet versus duplet, and you can see overall response rate is significantly better. Progression-free survival is significantly better. The hazard ratio is very impressive, actually. And overall survival was significantly better. So all the efficacy aspects were better. This particular trial included around 300 patients out of the 600. They had baseline brain metastasis, either stable brain metastasis or active brain metastasis. And you can see that for those with brain metastasis, the progression-free survival and overall survival in favor of tucatinib arm was even more impressive compared to overall population. You can see in the placebo arm, which was to trastuzumab and capecitabine, practically all patients with CNS metastasis, they failed within 1 year. While you have at 1 year more than 45% of the patients treated by tucatinib, they were progression free. So this combination is extremely effective in patients with brain metastasis, actually, and there was improvement in overall survival of patients with brain metastasis. And for those with active brain metastasis, that's to say brain metastasis that were not really treated or they progressed after radiation, again, the overall response rate in this 75 patients was in the brain was 47% versus 20% in the placebo arm. So this was the first drug, actually, the first combination that to be approved in patients with brain metastasis, whether active brain metastasis or stable brain metastasis. That's the first combination to be approved in breast cancer with HER2 positive. In China, we have the pyrutinib. Pyrutinib is pan-HER blocker like naratinib, but it has different pharmacokinetics. When combined with capecitabine and compared with lapatinib capecitabine, you can see that this combination is much better than lapatinib capecitabine. The progression-free survival duration was doubled, and the overall survival was significantly better with a hazard ratio of 0.69. So this drug is already approved in China, and it is very soon it will be in the Middle East countries. The Chinese later on they provided their data on capecitabine plus pyrutinib in patients with brain metastasis, HER2 positive, either not previously treated, radiotherapy naive. The overall response rate is 74%. This is one of the highest overall response rate in brain metastasis actually ever. And the cohort was around 60 patients, and it was as expected, much less, around 40% in patients who received the prior radiotherapy. In the ESMO 2 years ago, again, the Chinese group, they provided the FILA study, which very similar to Cleopatra study, but instead of giving pertuzumab, trastuzumab, they gave pyrutinib, trastuzumab, always with docetaxel versus trastuzumab, docetaxel, very similar to Cleopatra design. And you can see the improvement in progression-free survival was even more impressive than we have achieved with the Cleopatra. The hazard ratio is 0.41 versus 0.68 with pertuzumab. Of course, all the Chinese studies will always be criticized that these drugs might be more effective among Chinese, although I don't really believe so. But it remains to see more of studies of this drug, the pyrutinib. It seems extremely effective, even for patients who have received the prior trastuzumab versus no prior trastuzumab. The benefit is almost the same, and the overall response rate is above 80%. with the complete remission in around 7% of the patients. Lastly, the last part of this talk is the antibody drug conjugate in HER2-positive breast cancer. The antibody drug conjugate is a unique medicine. You have the antibody against the receptor, the HER2 receptor in this case, and this is the FAB part, the fragment antigen binding part, this part. But along the FC part, we have to select, and this is very sophisticated chemistry action. Actually, a certain site for to do the conjugation with a linker, and then this linker will link the chemotherapeutic drug, which is this one, to the monoclonal antibody. So you have sophisticated the drug chemistry for the linker, and of course the drug, you need very potent chemotherapeutic drug that can act in sub-nanomole potency, extremely toxic drugs actually. And the antibody depends on the number of the receptors, the copy number of the receptors. And we know that the HER2 overexpression, they have extensive number of receptors, more than 2 million. So for any antibody drug conjugate, you need a minimum of 100,000 receptor per cell. And this antibody with the receptor should be internalized. And we know that in HER2 that we have extensive number of receptors when the disease is HER2 positive, and we know that trastuzumab induces internalization of the receptor. When trastuzumab as an IgG binds to the receptor will be internalized. So the drug developer thought if they bring trastuzumab and they bring a chemotherapeutic agent, which is DM1, a very potent antimitotic drug, and bring a stable linker in the circulation, when you bring them together, you will have the trastuzumab DM1, which is the first in class. That was the very first antibody drug conjugate in solid tumors. Anyway, the TDM1 will come to the HER2 receptor. It will bind to the subdomain of the receptor, which will internalize the receptor and will bring the chemotherapeutic agent to be present intracellularly and to induce a potent antimicrotubular effect. This will induce cell toxicity very straight. Importantly, the TDM1 does not have the capacity to diffuse outside the HER2 positive cell. So it doesn't exert any effect on the nearby HER2 negative tumor cells. What we call, it doesn't have bystander effect. We have known that TD1 is a very good second line treatment when it was compared after failure of trastuzumab and paclitaxel, when it was compared with capecitabine, lapatinib. You can see the response rate, the progression-free survival, and overall survival was significantly better than lapatinib, capecitabine. And again, that is the Emilia study in the second line. In the third line, we have the Teresa study, TD1 against any trastuzumab-based chemotherapeutic regimen. At third line, again, you can see the same improvement in the same hazard ratio in improvement in progression-free survival and overall survival. So TD1 is a very reliable drug, but let's see that the bad side of having a good drug sometimes is the HER2 heterogeneity. You remember when I told you the score 0, score 1, 2, 3, and the HER2 plus 3 is the one you're seeking. Some patients, they have this kind of a tumor, what we call HER2 heterogeneous tumor, where you have HER2 plus 3 here and here, while HER2 score 1 here, score 2 here. So eventually the pathologist will tell you it is core 3 because it is more than 10%. But if the biopsy needle was put in other sites, the diagnosis would be HER2 negative. But anyway, why we have HER2 heterogeneity in breast cancer? We have two mechanisms of having HER2 heterogeneity. Either you have amplification of HER2 gene in some cells, that's to say, some of the cells are FISH positive, and this will lead to HER2 protein overexpression, where some of the cells, they have HER2 gene not amplified, so you will have absence of HER2 protein in other cells. So that's like this patient, for instance. Another mechanism is that all the cells are HER2 positive. They have amplification of the HER2 gene, but some of the cells actually, they overexpress the protein, while the other cells, they have what we call epigenetic silencing of the protein. The cell has the gene, but is not able to form the protein. But anyway, by the end of the day, you have HER2 heterogeneous tumor, and HER2 heterogeneous tumor, of course, it will end up by inaccurate assessment of HER2 status, because the pathologist will give you the reading of the site where the needle biopsy was done. For instance, if it was done from this area, the pathologist will tell you it is HER2 positive. But if the biopsy was done in this area, it will tell you it is +1 or +2. Anyway, during the last several years, we have known that intratumoral HER2 heterogeneity is a real reason for failure of anti-HER2 therapy, especially actually a drug like TDM1. This is the data from the Christine trial, where the TDM1 was used as neoadjuvant treatment, and the investigators, they defined the HER2 heterogeneity according to certain percentages of HER2 amplification, more than 5%, but less than 50%. And here we are. In this study, 10% they have HER2 heterogeneous expression. That is the PCR rate. If you give TDM1 in patients with HER2 heterogeneous expression, PCR is 0. Or if it is HER2 non-heterogeneous, that's to say homogeneous expression, the PCR is in the range of 55%. So the TDM1 actually is a drug that is really suffering in patients with HER2 heterogeneity. We have seen much lower rates of PCR with TDM1, and also with other agents, but with TDM1 specifically, it is very low because it has lower level of HER2 protein in parts of the tumor, and possibly require different treatment approaches. So the different treatment approaches actually is try to improve over TDM1. That is the structure of TDM1. For each monoclonal antibody molecule, you have around 3 to 3.5 molecules of chemotherapy, what we call drug antibody ratio, 3.3 to 3.5. And the drug, which is the DM1, it is a very potent drug, but it is not able to exert membrane permeability. So you will not find this drug outside the HER2 positive cell. The trastuzumab deruxtecan was constructed with the aim of having much higher antibody to drug ratio. It is 8. So with each trastuzumab molecule, you have more chemotherapeutic amount. And this chemotherapy, which is the DXD, is topoisomerase 1 inhibitor, is a cousin of irinotecan, which is the Camto. And this drug actually, it has membrane permeability. That's to say, it's able to get outside the tumor cell, the HER2 positive cell, and go to the nearby HER2 negative cell, which we call bystander cytotoxic effect. The Japanese, they pioneered this technique. They have for the first time a tumor model with HER2 heterogeneity in the animal model, and that is the presence of HER2 positive tumor uh, beside an area of HER2 negative tumor. And this HER2 heterogeneous animal model was treated with DXD, and you can see after treatment the tumor, the HER2 positive and the HER2 negative disease, they totally disappeared with DXD, trastuzumab DXD. And in the same study, the estimated tumor volume actually with trastuzumab DXD was the least versus TDM1 was practically resistant to treat this HER2 heterogeneous tumor. It was when you see this data, automatically you think, why not to try the trastuzumab DXD in patients who really failed TDM1. And actually, that's what happened in the Destiny-01, which was a large phase 2 study, more than 180 patients, extremely heavily pretreated, the median number 6 prior lines, and more than 91% received 3 or more lines during the metastatic phase. And of course, everybody failed TDM1. And here we are, the results. When we saw these results more than 4 years ago, overall response rate 60%, and duration of response of 18 months, progression-free survival 19 months. That was unbelievable for a very heavily pretreated population. We saw in this patient population a serious side effect of this drug, which is interstitial pneumonitis, that was fatal in around 3% of the population. But anyway, that was the first time to see a drug since ages, to see a drug approved with a phase 2 study, actually, because of unprecedented efficacy. But we needed to confirm the efficacy of trastuzumab DXD in 2 subsequent studies, the Destiny-02, which included patients who all of them failed TDM1, and Destiny-03, which compared in a head-to-head comparison trastuzumab DXD versus TDM1. Let's see first Destiny-02. It was done to confirm the results of the Destiny-01, which is the efficacy of trastuzumab DXD after failure of TDM1, and they compared against trastuzumab capecitabine or lapatinib capecitabine versus trastuzumab DXD. Around 50% they received the prior 3 lines or more in the metastatic phase, so they were heavily pretreated, not as heavily pretreated as Destiny-01. Everybody, of course, received TDM1, and around 3/4 received the pertuzumab, and 100% received paclitaxel. That is the unbelievable results of trastuzumab DXD. The improvement in progression-free survival, as you can see, more than tripled prolongation of progression-free survival in favor of trastuzumab DXD. And in all subgroups, the prior pertuzumab, it doesn't matter if it is the patients received prior pertuzumab or no, the progression-free survival benefit is the same. If it is prior brain metastasis at the baseline, the importance, the performance is the same. Prior lines of treatment, more than 3 lines or less than 3 lines, the drug is producing the same progression-free survival, 18 months if it is more than 3 lines, and 16 months it is less than 3 lines. So it is across the board. The benefit is extremely impressive. And that's the progression-free survival in 01, it was 19 months, and in 02, it was 17.8 months. So you can use it, of course, in all failures of TDM1. Again, in the Destiny 02, DXD improved the overall survival by more than 1 year, and the improvement actually was seen again in overall response rate, which was more than doubled the overall response from 30 to 70% in favor of trastuzumab DXD. It's an unbelievable, actually, improvement. The Destiny 03, which compared in a head-to-head fashion trastuzumab DXD versus TDM1, the patients were not as heavily pretreated as the prior two studies. 50% received their treatment as second line, and 50% beyond second line. Pertuzumab was given in 2/3 of the population. Let's see the outcome, actually, again, unbelievable. Remember, we were very much impressed with TDM1, but now the TDM1 versus DXD, the progression-free survival is more than 4 times longer in TDXD versus TDM1. Again, in all subgroup, as we have seen, prior pertuzumab does not matter. The performance is the same, the hazard ratio is the same. Prior lines of treatment, if it is 2 lines or more than 2 lines, the outcome is the same. Presence of baseline brain metastasis, the outcome is the same. Overall response rate is 80% in second line and beyond versus 35%. Again, in hormone receptor positive or hormone receptor negative, prior pertuzumab or no prior to pertuzumab, visceral metastasis or no visceral metastasis. Across the board, the drug is having more than 40% improvement in overall response rate, better than a very good drug, which is TDM1. Overall survival, later we have seen significant improvement in overall survival. And what I don't like, of course, in TDM1 is it is a tough drug. It induces much more anemia and neutropenia and leukopenia compared to TDM1, but it has less thrombocytopenia. It is not zero thrombocytopenia, but it is significantly less thrombocytopenia compared to TDM1. When it comes to nausea, vomiting, constipation, diarrhea, fatigue, headache, you have a lot of problems with trastuzumab DXD versus TDM1, especially for nausea and vomiting, diarrhea and constipation. Fatigue as well, headache as well, alopecia as well. Weight loss is very significant, actually, with this drug. Transaminitis is higher with TDM1, but it is not zero with trastuzumab DXD. When it comes to interstitial lung disease, again, the incidence was 15% versus 3% for TDM1. It is not zero for TDM1, by the way. But in this study, with patients not heavily pretreated, we did not witness grade 4 and grade 5 toxicity. The presence of left ventricular decrease was more seen with TDM1, was more seen with trastuzumab DXD versus TDM1, but again, it is not very high. The quality of life actually is we need to know is the summation of many things, the disease-related symptoms and the treatment effect. The treatment effect, the beneficial part is tumor shrinkage, and the bad part is the side effects. So the quality of life is the combination of the effects of the disease-related problems and the treatment-related benefits and problems. Unfortunately, for the Destiny 03, you can see that trastuzumab DXD did not improve the quality of life compared to TDM1. At 9 months, the median deterioration, time to median deterioration was 9 months versus 8 months for TDM1. But if you look at the progression-free survival of trastuzumab deruxtecan, it was 28 months. Time to deterioration of quality of life was 9 months, which means that the patient would live something like 1.5 years with deteriorated quality of life, actually, with trastuzumab deruxtecan. That is how it went with nausea and vomiting. The lower curve is TDM1, the upper curve is DXD. Now we know that we have to prepare our patients who are going to receive DXD with the same antiemetic regimen that we utilize with platinum, for instance, because it is a highly emetogenic drug. But of course, the unprecedented benefit of trastuzumab deruxtecan is worth noting. Progression-free survival as third, fourth, and fifth line is at least 18 months. If it is given as second line, the progression-free survival is 28 months, which is longer than any first-line treatment, actually. Whether it is preceded by TDM1 or pertuzumab, the efficacy is always the same, almost. Overall response rate more than 60% in the third and fourth line and beyond, and it is around 80% as a second line, whether preceded again with pertuzumab or TDM1. In brain metastasis, we have seen it is very effective in brain metastasis in the prior studies, but in other studies, smaller cohort trials, like the Tuxedo study or the Deborah study, again, the response rate in the brain, it ranges from 45 to 70%, which is very impressive for brain metastasis. During the last ESMO, we have seen the Destiny 01, 02, and 03, the pooled analysis of patients with brain metastasis, and they included patients with brain metastasis, 148 patients treated by trastuzumab deruxtecan versus 83 patients treated with the comparator arm, which was mainly TDM1 or trastuzumab or lapatinib capecitabine. That is the intracranial overall response rate in all the studies. Intracranial response rate of 45%, whether active metastasis or stable metastasis, versus 27 and 12% for active metastasis when we use TDM1 or other agents. Again, that's the progression-free survival in patients with stable metastasis and active metastasis. The performance in active metastasis actually is unbelievable. So this drug will help you much if your patient has brain metastasis, whether it is stable or active or progressive brain metastasis. You can depend on this on this drug very much. At the present time, we have ongoing trial to utilize trastuzumab deruxtecan versus the Cleopatra study, and I'm sure that trastuzumab deruxtecan will be better than the Cleopatra regimen, the taxane, trastuzumab, pertuzumab, but it will remain always the quality of life, which will hinder, in my opinion, utilization of this drug as a preferred first line compared to the Cleopatra regimen. I think that's my last slide for today. I tried to cover everything related to the HER2-positive disease before the era of targeting therapies. The benchmark was the introduction of trastuzumab, and at the present time we have more than 8 approved drugs or 9 approved drugs as anti-HER2 in the metastatic phase. Next week, inshallah, we will discuss the adjuvant, neoadjuvant, and we'll try to cover the HER2 low